what we call okay, let me just continue on. Okay, so what we call the building blocks of a quality management system, because it's not just one piece. It's not just about QC tools. It's not about Westgard rules. It's the entire system. And what we call a building blocks. We have 12 different things has to be put in place before we have a good quality management system. And then another objective is to apply these quality control tools to manage process. What does that mean by managing process? Managing process means that everything that you do every day in the lab is a process, but every one of these process that you do must be managed properly. And then when this process goes wrong, what do you need to do? What we call when the spurious results happens, you have to take actions to make sure that these wrong results are corrected. And also, when things happen, will your staff know what to do? And those should be written out in what we call the SOP, Standard Operating Procedure formats. So those are objective. After 1 hour, hopefully, or less than 1 hour, hopefully we can accomplish all that, and you can bring it back to your lab and be able to implement some of that. So when we talk about quality, different people have different idea what quality means. Okay, when you go to McDonald's, the hamburger doesn't turn out right. The quality, we call it the quality is bad. What do you mean by quality bad? You ask another customer, they will say, well, I think it's okay. I think the quality is okay. I mean, you drive a car, the car is okay, but to one person is okay, to another person is not okay. So quality actually is based on what the customer needs. So that's why the definition of quality is the totality of characteristics of an entity that bear on its ability to satisfy stated and implied needs. In other words, is what the customer actually tells you what they need. In the healthcare system, in the laboratory, your customer, the key thing is your customer are your patients as well as your physicians, because you provide information to physicians. And the second definition of quality is that the degree to which a set of inherent characteristics fulfills requirement. Those big words, what that means is that to make a good quality product, what are the things that will make a good quality product? So keep that in mind, but you don't have to remember these definitions, but the key thing is what the customer needs is quality, okay? So the next slide, let's see. Oh, how come I'm frozen here? Okay, let's try that. Okay, so one thing is very important is that at the right-hand side, you'll see what the patient and client needs. In order to have a quality system, you have to make sure that there's a continuous quality improvement. It's just rolling a ball up the hill until you roll it up to the top to meet the patient needs. And to be able to roll up that ball to get quality, you have to have 4 things. One is to plan what you need to do to meet the client needs. So plan what you do and then do according to your plans. And then when you're done with it, when you finish doing or during the process while you're doing it, you constantly check and make sure that the goal that you initially design or you initially want to reach, it's being met. So you're constantly checking. Okay, you're checking with the customers to see whether, and also you're checking with your plan. Make sure you're not deviating from the plan. And then if they do deviate from the plan, you act on it, you change it. Even you have to change course, you change tools. You constantly applying this plan, do, check, act to meet those requirements. And then that requires a constant rolling of the ball, constant change it until you reach the goal. So it's not an easy process. That's why that you see the hill actually is a hill that slants up. It's constantly moving upwards. So a quality system embraces both the pre-analytical phase, or what we call the pre-examination phase, examination phase, and a post-examination phase. And these 12 building blocks, actually, if you look at it, the bottom level, and then the 2 and the 3 levels above, it represents the plan, do, check, and act until you get to the top, continuous improvement. So you need the organization. In other words, you need someone you need a lab organization. You need someone and then you need someone who's the boss. You need someone, all these 12 different blocks. We are not able to talk about all of them today because it is a course in quality system. It's a course on quality management. So we're going to highlight basically 3 things. Process management, as I said, everything that you do in the lab is a process. And then we need people to do the job, that's personnel. And then another thing that is very important in the lab is that everything we do, because we provide information, so everything you do has to be documented. If someone brings you to court, you don't have proper document, then the judge will say, I don't see the proof that you have done this. I don't see the proof that tells the staff how to do things. In other words, I don't see the SOP that tells the staff what to do. Then, in other words, the staff can do whatever they want to do. Then there's no record. Then you will be in the wrong. So I'm highlighting in these 4 case studies that 3 things, as I said, will be highlighted: personnel, document and records, and the process management, plus maybe a little bit of the equipment. That equipment, we'll talk a little bit, the equipment limitation and all that stuff. So case one will be a patient being admitted to emergency, a 76-year-old lady. And it was a lovely day, and she went out to do some gardening during the daytime, and she was feeling well, and she went out she went back home after she finished gardening and made a meal. She lived by herself, and then suddenly she experienced, after dinner, she experienced back pain and started to vomit. And then she phoned her friend up and say, hey, I'm not feeling well. Can you take me to the hospital? When she was gone to the hospital, the doctor accepted this was 10 o'clock already at night, and they check her out. The vital signs seems to be relatively normal, and then she was alert and oriented. In other words, she knows where she is, but the doctor noticed that she really doesn't look good, despite the fact that her vital signs are all normal, which is kind of interesting. So lab test was ordered. The initial lab test result is the lab test was drawn at 10:05. And you can see from the panel that the red count is low, hemoglobin is slightly decreased, MCV is decreased. And the only thing that is alerted to the technologist is that MCHC is 45.9. In a normal sample, the MCHC should be around 37, depends on your lab, 37 or 36.5, that type of thing. So, and the platelet is normal, hemoglobin 7.8, and there's NRBC present, depends on the type of instrument you use. Some more sophisticated instrument will give you actually an NRBC, a nucleated red blood cell. And so, and also sophisticated instruments would also correct for the WBC, correct for the NRBC as well. So the initial WBC was 9.2, corrected to 7.8. The neutrophil and all those are pretty normal, except there's 5 NRBC per 100 WBC. So the technologists follow what she was told, is that the correct for the high MCHC, so warm up the sample and rerun it. After she warmed up the sample and reran it, it didn't help. So she spun the specimen down, tried to do a plasma replacement, thinking that it could be a lipemic sample. And then when the technologist spun the sample down, she said, oh, this is odd. The sample did not spin. So, and that's what it looked like. It looked like the whole tube is not being spun down. And upon close examination, this is a close-up of that sample, an aliquot of the sample. You can see there's actually a little bit of the button at the bottom. The rest of them is all red. In other words, the sample did get spun down, only a little bit of whatever sediment is there. And then And then she looked at the histogram itself. As you can see, those are the numbers. And then she also did a spun hematocrit. In other words, you just use use those hematocrit to spin it down and give you the hematocrit of 0.1 versus the instrument's hematocrit was 0.22, which is drastically different. Right? She realized that she is dealing with something that is very, very abnormal. And even for those who are familiar with histograms and scattergrams, these are very abnormal, and the histogram definitely is abnormal right here, right? And so she actually phoned the pathologist. Now, don't forget, this is at night, and I think there's another person with her. And so she phoned the pathologist and she explained what she had done. And then saline replacement give you the result. The hematocrit was 8%. Now, from 22% down to 8%, which is the machine gave 22%, right? So, which is very, very different. And 8% in hematocrit, nobody can call an 8% hematocrit a normal hematocrit. And the hemoglobin was 31. And then from the previous slide, that the hemoglobin, the machine gave you the hemoglobin of 101, but the saline replacement was 31. So as we can see from the sample itself, there are lots of hemolysis too, right? So a good technologist, what they do is they are not just focusing on, if you're a hematology technologist, you're not focusing on the results coming out from your own department. You also focus on the results coming out from other departments, such as chemistry. And if required, you also communicate with people from, let's say, even microbiology, right? So she looked at the chemistry results, LDH, very high, bilirubin, very high. Everything is abnormal except the ALT, okay? So the first three parameters there indicate that there is significant hemolysis going on, right? So she knew that there is something not quite right. Now I'm going to show you the plasma saline replace sample, 101. Sorry, red count actually is dropped back from, let's see, the red count was 2.93, the original sample. And then it came back to 1.01. So in other words, whatever you have at that little button that was spun down, it's only very, very little amount of red cells. So obviously there's severe hemolysis. So she realized that she's dealing with something that is very abnormal. She took a look at the slide. And that is something that technologists sometimes, when they see something abnormal, they basically froze. They didn't know what to do. So with this text, she said, okay, all these things telling me there's something not good. So I better look at the slide, right? So, I should just go back. Yeah, this is all the things that she did. And you can go back to this slide later. And then remember, one of the QA2 was 3 times rule last time we talked about. So she applied all those QA2s, QC tools, and realized something abnormal. Okay, 3 times RBC equals hemoglobin, 3 times hemoglobin is hematocrit. On the initial sample, it failed, and saline replace sample, it corrected, right? So she looked at the slide, and that's what the slide shows. So again, when you look at the slide, make sure that you don't just be so excited about the obvious. You have to be excited about the something that is not so obvious as well. When you just look at this slide, you say, okay, there are lots of, there's some red cells and they're not of red cells, which is what is indicated from the slides that I show you, because the red count is only 1.01, right? So that's why there are only a few red cells. But on a normally prepared slide, there should be a lot of red cells. But on this slide, there's only a few red cells, as you can see, the red dots. But there are lots of little holes. I hope that you can see these little holes, lots of holes on the slide, right? So these are what we call the gold cells. Gold cells are basically the red cells that the hemoglobin is not there anymore. Then there's still some platelets, so that means the slide is prepared properly because there are proper amount of platelets. There are not too many white cells there because we did some replacement. Maybe we lost some white cells along the way. But another thing that is not as obvious is the spherocytes. Now, this is a normal red cell, right? You can see the center pallid. It's not that's what the normal red cell look like. But the abnormal red cell are these ones that there's the hemoglobin, the lots of hemoglobin. This is what we call the spherocytes, right? So she realized that there's gold cells, the spherocytes, and also the red cells are low. Okay. There's someone trying to come in. Okay, good. Yeah. So higher magnification again show that there's holes. Now, don't mistaken these so-called holes as sometimes people say, oh, the slide is dirty, that's why you have holes. But don't forget, you look closer. If it's dirty slide, though the oil droplets, these holes are not uniform. But in this case, every single hole look quite uniform. They're the size of the red cells. That's why these are gold cells. Okay. So again, that's 100 magnification. Just illustrates how the my computer is somehow not responding as well. Okay, let's see. Try this. Okay, so and then she started to scan the slide. This is pull it back, and she realized that there's something right here. Okay, so this is debris. This is debris from dirty stain or whatever, and these are platelets. These are platelets, and these are bacteria. Okay, so now another mistake commonly made by technologists is that sometimes people, especially with students, they look at this as, oh, this is a gram-positive. No, this may not be gram-positive because this is not a gram stain. This is a right stain. So just because you're able to see this as a purple color, darker color bacteria, you call this gram-positive, and you're going to report back to the pathologist and saying that this is gram-positive. No, this is not. You just the only thing that you can describe to someone else. Oh, let's say you have to phone the doctor, and then you can only describe to them is that you see a rod-shaped microorganism. You suspect it's microorganism, but you cannot confirm this microorganism until you have microbiology to prove that. But you will tell the pathologist, you'll tell the doctor or in emergency that you suspect that you see something, and because the doctor have to tie this all in with the clinical picture of the whole thing. So again, higher power, this looked like two not gram-positive, but rather two rod-shaped bacteria. So now, when this information is passed on to a pathologist or passed on to a doctor who's in charge, you tell them that there is low hemoglobin, very low hemoglobin, the sample is totally hemolyzed, and also there's lots of gold cells and there's spherocytes. And they can put 2 and 2 together and then realize that, there's something wrong. And then from your end, you also have to recognize the limitation of the analyzer, as we have mentioned, that, first of all, you have to understand the principle of detection. First of all, is that for most hematology analyzer is that there's some calculated parameters, there's some measure parameters. And with the measure parameters, you have to know which one is measured in what way. So for most analyzer, your white count and your hemoglobin are measured in the same chamber, whereas your red and platelet is measured in another dilution in another chamber. So when you do troubleshooting, you have to recognize that. You have to understand the principle. Otherwise you'll be just a press button technologist. The reason we are different, hematologists are different than chemistry technologists, because we understand We understand things, and we try to, and we are not just pushing button and generate a whole bunch of numbers. We know how to troubleshoot as well. Sorry, I'm not belittling any technologists who does a lot of chemistry. I'm just saying that hematology is different. But we also have to recognize that the limitation of hematology and analyzers as well. So these things, I'm not going to repeat it again, because most of you know about what MCHC is sensitive to, such as, one thing I do want to draw your attention is the osmotic imbalance, that is high or low sodium and potassium, but that's a different topic, because this case doesn't involve this kind of interfering substance. So gold cells we recognize. We also recognize on the histogram, which, remember, I'm not going to go back to that slide, but look at the histogram. Remember, I just mentioned is that the red count and the platelet, sorry, yeah, that's right. The red count and the platelet, they share the same channel. The white count and the hemoglobin, they share another channel. So once you recognize that, you look at the high tip-off. In other words, you recognize the interference substance for red cell and the interference substance for platelets. Okay, so you have to make sure that you understand that, right? So, and you also have to understand that the high MCHC can be caused by many different things, and one of the things, as you notice, is the spherocytes. So this, when you put all these interference substances together, you realize that explains all the things, that all the abnormal parameters that you see in your histogram that is generated by the instruments. Now, for those of you who have only the 3-part, the smaller analyzer that generate only 3-part histogram, they still have the red cell histogram, they still have the white cell histogram, they still have the platelet histogram. I hope you do. Okay, so the final diagnosis for this case is a Clostridium perfringens infection, and it's a very, very it's in some way it's a normal flora, but when it causes problem, it's very, very deadly, because it produced 12 types of toxins. One type of toxin, it's called the lecithinase. Lecithinase actually is, from the name of the toxin, you know that it's an enzyme that breaks down amino acid, breaks down something in the red cell phospholipid membrane, and because it breaks it down, that's why it causes hemolysis. And if it doesn't cause hemolysis, it will cause you gas gangrene and sepsis, hemolysis, and all the other bad things. So that's why in this case, it can cause massive intravascular hemolysis, hemoglobinemia, hemoglobinuria. And because all the red cells are being lysed, the potassium leaks out and causing renal failure. And it's a very bad disease in a way. If it is bad, it can get very, very bad, because it can kill you within hours. So in this case, it's what happened is that the patient was intubated 1 a.m. and then, because the patient went to a small community hospital, she had to be referred out. So within hours, we were going to put her in an ambulance, and she actually died in the ambulance. She was pronounced dead when she got to the large center. Okay, so the case one, I just illustrate to you how important it is to know what to do, to know when you see abnormal parameters. And even if you don't know what to do, you have to make sure that your lab have SOP. Your technology is able to look it up and find out what to do. And also, once they know what they decipher all those abnormal stuff, you're able to communicate to your pathologist, communicate to the ER doctor on what you found. Because in this case, I know that in this case, even if the doctor, the technologist did everything right, but is still not able to save the patient. But we have tried our best. But it tells you the severity of the diseases that sometimes we deal with. I mean, sometimes technologists just don't see their own value. I see on the website people complain about what they do, but you have to realize you play a very, very important role in the patient care. Okay, the next case is similar. I just want to just quickly check the time, making sure that I'm on track. Okay, I have to push a little bit. Okay, case 2. The 2 families, actually they may even be families, 3 families. They were vacation in summertime. The family have a cottage in the country, and so they were vacationing. Now, don't forget, when we say a country cottage, that means that the place is not looked after during most of the year. They only go back maybe during the summer months, because usually, and when they go in, they have to clean it up, tidy it up before the house guests or the family arrive. So the father went in there a day ahead and then cleaned up the place, and the rest of the family arrived. But about five days or 7 days into the vacation, the patient did not feel well. Okay, so the patient had headache, chills, vomiting, nausea, and then she thought, oh, maybe it's just getting a flu. At that time, there was no COVID, so there was not a COVID case. And then later, her sister was not feeling well as well. So they decided to, okay, we better at least go to the hospital or cut the vacation short. So the first patient came back to British Columbia, and her sister went back to her home in the United States, because they just lived very close to the border. And CBC result of the first patient, the white count 6.4, hemoglobin 130. Those are relatively normal CBC result, except there's a suspect flag now. Suspect flag, some of you who use small instruments may not have suspect flag of immature gram, but the larger instruments do. So I'm going to show you this case through what I call the virtual slide. So basically, it's just a slide. It's not a good slide because there are lots of streets. But I just going to, in other words, this is in a thin area. Normally, you don't, when you pick up a slide, you will scan a slide, and not lots of people say, oh, when this slide need a differential, I will do a differential and find a good area to do the differential, and they will go ahead and do a differential right away, which is a wrong way of doing things. When you pick up a slide, you should have an SOP tells you when you pick up a slide, you use 10 power, scan the slide in the thin area as well as the thick area. You would spend about 30 seconds to 1 minute just to scan, give you an idea of the overall landscape of the slide. What are you dealing with? The white cell estimation, and then you will scan the slide using higher power to do the platelet estimation, give you a general impression of what the slide is. Now, I'm not sure. I hope that your lab have an SOP telling you how to scan a slide. Right? Because most people will say, "Oh, I know how to scan a slide," and then lots of technology will say, "Okay, this slide requires the differential." So they immediately put the slide under the microscope. They go right up to 100 power and do the differential, finish the differential within 2 minutes or 1 minute, and then they move on to the next slide. That is totally wrong. Okay, this slide will illustrate to you why is it important to scan the slide. Now, in this scanning, you're low power. So right now, as you can see on my screen, so this is about eight times or whatever, right? So it's about 10. Normally, most people have a 10 times zoom, 10 times objective. This is what you scan, right? So you basically look at, okay, this looks like the white count is about this. This is in a thin area. So the white cell estimation doesn't reflect the true white count. But tells you, at least it tells you that there is a couple of neutrophil and whatnot. And then you move on to higher power, and then let's see, okay. Sorry, I make you dizzy as I move this, okay? So you get to a 40x, and then you scan, and then now, as I said, looking at this, doesn't do justice because it's not a real slide. It makes everything looks very flat. The rest cell looks very flat. Under the microscope, it looks a lot better, right? But when you scan, you just also, so usually in my SOP, I have processed how to do 10 times scan, what to do with 40x, what to do with 100x. Okay, so but I'm not going to go into it. I'm just going to tell you that it's important to do a systematic scan. So when I scan, I would just move along now under 40. So there's not much to see. But again, if you are good under the microscope, then you would just move it along and then look at things, right? So there's not much to see. But on the other hand, you have to be vigilant when you scan. Now, I'm going to beam it up to higher up to 80 because I want to illustrate about this case. So this looks like there's not a whole lot to do here other than, oh, there's a lot of background noise here, right? But okay, there's a monocyte and whatnot. What else do you see? Right? So, but then if I'm going to tell you what I see. Okay, so if you look closer, if you just look at it and say, oh, this looks like doesn't have a lot here on the slide. But don't forget, if you are a good technologist, you're able to pick up there is a little wiggly thing there. You may just dispel that, oh, this is nothing. This could be just contamination. Maybe it's something dirty on the slide. But this is definitely not something dirty on the slide, because from my arrow, you can see there's something here as well. There's something else here, right? So they all look they are like this. Okay, if you move to a different area, so there are actually quite a few of those. If you scan it, if you look at it closer, I'm going to just to save some time and then show you where they are. So you have one right here, and then you have another one. Should be nearby as well on my screen. Oh, so one here, right? And then another one here. All right. These are what we call spirochetes. They are bacteria. And so I'm going to move that back and see if it will go back there. Okay. There we go. So in this case, the patient, now this technology is so good. I think this was her last shift of her career because she was going to retire the next day. And this is really top it off because she was able to find this bacteria and report it to the doctor that she found this spirochetes. And this is still image. And again, it is right here. The spirochete is right here. Can you see? I hope you can see that, right? It's not that obvious when you first glance look at it. And also there's toxic granulation in some of the neutrophils. Again, there's another spirochete right here. So another one, right? So this spirochete is called the Borrelia Hermsii, or it causes relapsing fever. Relapsing fever, in this case, for this particular bacteria, is for this particular bacteria, it actually it causes a relapsing fever, and so so the cycle of infection is through rodents. In other words, through the squirrels, through mice. And what happened is that because the cabin has been so-called abandoned for so long, and during the winter months, so squirrels gets in there, mice get in there, and then as the male household went in there to clean up the place, the mice drop in, start to fall down. At night, some family members just happen to sleep nearby and they inhale some of this things that is floating around, and then a couple of the family members get infected. So the cycle of infection is 7 days of it takes 7 days of incubation, and 3 days to cause a fever, and then another seven days of a febrile period, and the cycle repeats itself.
Thanks.
Is it causing a lot of feedback? Okay. There you go. So that's the, and I'm sure, I mean, relapsing fever is especially in this Borrelia infection, it occurred in certain parts of British Columbia and certain part of United States as well. I don't think, but I'm sure in your country, in Trinidad, you may have different kinds of bacteria. But this case is just to illustrate to you, when you scan a slide, use a proper procedure of scanning, okay? And case three, let's move on, is it's a 2-year-old male, had flu-like symptoms for 1 week and losing appetite and admitted to ER. And the technologist, when she ran the CBC first time, that give you a high white count, in other words, not able to spit out some results. She made a 1 in 2 dilution, 1 in 5 dilution, and still not able to get a result. And she started to panic because this case happened when I was, because I had to visit hospitals. I just happened to be there visiting a hospital. And then they were so excited to see me that, as a kid, I don't know what to do because I cannot get a decent white count on this patient. I said, well, you cannot get a decent white count. Just do a random dilution. You've done a 1 in 2 dilution, done a 1 in 5 dilution that failed. Look at the slide. So that's what we did. We look at the slide and realized that, boy, look at that. There's more white cell than red cell almost, right? So I told the technologist that because the white count is so high, just whatever you do, just do a 1 in 20 dilution. If it doesn't help, then 1 in 25, 1 in 30 dilution. It's bound to get some results. So we did I don't even remember what kind of dilution we did. We eventually get a result, and this is what, and also when it becomes making a slide, there's no point of looking at a slide that's just jam-packed with white cell, because you won't be, first of all, it won't stain, right? Because it's so thick. So you need to dilute it down. When I told her, I said, just put 1 drop of the blood in there, do 50 drops or 20 drops of saline in to dilute it down. I don't care about what kind of dilution. You just want to look at the slide to get an idea what the cells look like. And that's what it looked like here. Okay, I think I don't need to show you the virtual slide, because that's what it looked like in general. Lots of mononuclear cells. Some of them look very abnormal, like blastish looking. Now, one thing I'm sure lots of you, for those people who have dealt with pediatric samples, newborn or young folks, the slides for young kids are very difficult. The lymphocytes, right? So in this case, lots of them look like normal, but they don't actually have a lot of cytoplasm, and they look like, some of them, this definitely look abnormal, right? This actually is a case of childhood ALL, acute lymphoblastic leukemia. It's challenging white cell morphology, because for those of you who don't deal with a lot of young pediatric samples, that's not easy to deal with. But again, no one that has high white count. The white count turned out to be over 1 million, right? So because, again, your SOP should tell you that when the white count is that high, your hemoglobin will be invalid, and you should do what you need to do to get a valid white count. Okay. Some of the sophisticated instrument will give you a high hemoglobin turbidity flag, and it will alert you that you should do something about it. Again, there's a limitation of your instrument, as well as your SOP should tell you what you need to do when you come across such situation. So let's move on. This is a case 4. It's a 65-year-old male, and white count is 68 and hemoglobin 99. Again, your SOP should tell you at what level of white cell your hemoglobin may be affected. Now, this, again, I do have a virtual slide, but I don't think I have a lot of time to show you. But I'm going to just show you as the image what it looked like. So when you look at this slide, it looks like there are lots similar, very similar to what you have with the previous slide. Lots of mononuclear cells, small cells. Again, lots of looks like lymphocyte. But again, don't be distracted by the obvious. Right, this guy is a 65-year-old. And you look at, oh, there's also smudge cells as well. Now, don't be, but when you pick up a slide, when you do a differential, don't be just focusing on one thing, because quite often we are distracted by obvious things. In this slide would be the obvious things actually is your lymphocytes, right? Your lots of lymphocytes. There may be that there's also smudge cells. Oh, it's easy to do. This is an easy case. I can finish the 100 cells differential within 30 seconds, because this, I can report this as 100% lymphocyte. Wrong, absolutely wrong. Because once you finish that slide, then you miss out something very important here, such as you're missing out on, in this case, there are lots of spherocytes that you missed out. These are the spherocytes. Right? If you just, I'm going to report lymphocyte, I'm going to report smudge cells, then the most important thing, actually, another more important thing is the hemolytic anemia in this case, because in CLL, it's not uncommon that you have autoimmune hemolytic anemia. And if you just focus on the lymphocyte, ignore the red cell, then you forgot, then you miss out some very important information, right? And as another important lesson learned from here is that oftentimes, there's one question that when technologists, when they deal with CLL, is that should I do, well, on the SOP, obviously you have to do a albumin slide, right? So one thing that is, one mistake often made is that technologists will use the albumin slide to do everything. They use the albumin slide to get rid of the smudge cells, to do the differential, but they also use the albumin slide to do the morphology. When you use the albumin slide to do morphology, potentially everything will look like spherocytic. Every red cell will be spherocytic. So that's why in my SOP, it will say that when you do a CLL patient, obviously you do albumin, you use the albumin slide to do the differential, but you should always go back to the original slide to do the red cell morphology. Okay, that is extremely important. Another very important thing is that people don't realize that your smudge cells is an in vitro phenomenon, right? So I would rather take the automated diff, which counts 8,000 white cells, right? But the reason is because when you do a manual diff on a CLL patient, you are counting, let's say, even if you do 100 cells, 200 cells, you can easily just report 100% lymphocyte. But if you don't do proper screening, you may miss out on maybe the patient actually have some neutrophil, maybe not as many, but you should still report the neutrophil present, occasional neutrophil, because that will indicate the patient may still have some defense mechanism there, because the neutrophil may still be there. Because at one time, there was one patient we had of CLL, the doctor actually came back to tell us that, does a patient actually have neutrophil? You have reported, 100% lymphocyte. I want to know whether the patient has neutrophil, right? So you must scan the slide. If you see neutrophil, report occasional. Even the best part is you should report the automatic differential. If after you scan in the slide, you realize that these lymphocytes are truly lymphocyte and not pro-lymphocyte, then and not blast cells, then the best thing is to go back to the automated diff and say the automated diff oftentimes is much more accurate than your manual diff. Okay, so that's the case 4. So I think that's all the 4 cases. All right. So what are the lessons learned from these 4 cases? As I have mentioned, you have to understand the limitation, the methodology. The limitations are such as the interfering substances of instruments, and you have to know some of the QC tools. Another thing I did not mention is Kohlner Illumination, right? So Kohlner Illumination is important, because if you don't have proper Kohlner Illumination, you will not be able to see the spirochetes, because if the light doesn't come through properly, you will not be able to see some of these things. If your stain is not done properly, you will miss the spirochetes. If your stain is not done properly, then you will not be able to see the toxic granulation. If your stain is not done properly, you will miss out on the blast cells. All right, and that another key important thing of the building block is that of the quality management building block is documentation. You said that you've seen these things, but did you phone the doctor? When you phone the doctor, did you document that you phoned the doctor? Did you document what time you phoned? Did you document who you talked to? Did you document what you have done? Did you document you have done saline replacement? Right. So everything. The reason you have to document everything is in North America, the lawyers are very happy if you don't document everything, because if something goes wrong, when you get to go to court, when you are summoned to go to court, they will make sure that you look like a fool. Did you do this? If you tell me that you have done it, did you have proof that you have done it? If you don't have proof that you have done it, that means that you haven't done it, right? So regardless of all your effort, you haven't done it, too bad, so sad. Then that is your fault. Then you'll be liable. You can be sued, right? So another building block that is important, personnel. Are your people trained properly? Is there proper documentation they are trained properly? Have they participated in CE? Have they participated in continuing education? Were they graduated 50 years ago? They are still operating on the principle of that they learned 50 years ago. Technology has moved on. What have they learned so far, right? Organization. If you have to phone someone, do you phone the person? Do you phone a colleague, or do you have, when there's some important information to pass on, who are you supposed to phone to? Do you phone your pathologist? Do you phone your supervisor? This would be a chain of command. All these, again, when something happened, people have to know who to talk to. And when they talk to someone, everything has to be documented. So in these 4 cases, I'm only illustrating the 4 building blocks, but there are lots of other building blocks. Okay, so I think, let's see now. Let's see again. Properly. Let's see. Again, I talk about when you buy a piece of instrument, you have to know the limitation of instrument. Before you put the instrument to use, you have to do all these things listed on this screen here. All these things you have to understand why, and then you have to understand the limitation before you put the instrument to use, right? Because otherwise, if you don't know what the interfering substances are, then how are you, when the high white blood cell count, what is the limit of detection? What is the low limit? What is the high limit of detection? You have to know all of these things. And this is just an example of the SOP that we use so that people can follow. When the white cell count is above 250, what do they do? When they're above 30, when it's outpatient, what they need to do? When you come across neutrophil less than 1, what they need to do? Remember at the last webinar, when Trevor talked about the QC rules, one of you mentioned, oh, how do you know when to make a slide? An SOP tells you, in my SOP, it will tell you when the white count is below certain number, when the neutrophil is below certain number, you should make a slide. On the right-hand column here, it tells you when you need to refer to the pathologist, what action you take, that type of thing. The SOP should be very detailed. It covers everything, right? And again, when the instrument spit out certain flags, what do you need to do? Do you need to refer? Do you need to make a slide? What kind of follow-up action you need to do? This is about Kohlner Illumination. When the Kohlner is not done properly, it causes problem because the light doesn't come through properly, and you will not be able to see the things you need to see. And this is an example. This slide just shows you there's supposed to be the spirochetes in here. The Borrelia is supposed to be in here because the Kohlner is not done properly. You can't see this. You cannot see those things. So staining slides, lots of people, even experienced technologists, may experience some of these problems. Again, we can take a whole hour talk about how to stain a slide properly, and this is just you can look at the slide yourself, and because of the time we're not going to go through all that. In summary, we talk a lot about quality control. Quality control is just a part of the quality system. It should be just a part, but not the whole. In order to have good quality, you need a good quality system. You need the good 12 building blocks to have a continuous quality improvement system. And you have to have good SOP, and documentation is important. To be able to push that, remember the cycle, the plan, do, check, act, that rolling the ball up the hill is a journey. You have to set a goal, and it's not an easy, just rolling the ball up the hill. It's not an easy job, but with plan, do, check, act in place, then you should be able to implement a good quality system, and you should have, when you have all those in place, then you should have a very, very good lab. And that's all I want to say. Any questions? That I'm open the floor.